Thank you for giving this opportunity to share our information with a big number of participants. I think I'm sharing.
Yeah, you just need to.
Yes.
Yeah.
Is it okay?
Perfect.
Yes. I will try to give some information about craniovertebral junction injury and fixation techniques. In fact, this region has a unique anatomy, and we have to be aware of the measurements of the region. Although we do not use too much direct X-ray measurements, but we can still use them in the sagittal CT scans. One of them is Atlanto-occipital anterior atlantodental interval. It's 3 millimeter or less in adults. In children, it may be 4 millimeters. The other one is the posterior atlantodental interval. It must be more than 13 millimeters. If this is the measurements, this is the anterior atlantodental interval. This is the posterior atlantodental interval. There is one rule of Spence, although in the past we have used it too much. This is the displacement of lateral masses of C1 over the masses of C2. So this measurement plus this should be less than 6.9 millimeters. If it's more than 6.9 millimeters or 7 millimeters, it means the C1 burst fracture with tear of the transverse atlantal ligament has happened. The tear of the transverse atlantal ligament is a very important feature of the region. If it has torn, and then we expect the spinal cord compression, and also most of those cases will have neurologic deficits. However, then some other authors have examined the rule of Spence. It's not found very accurate for assessing the integrity of transverse atlantal ligament. 60% of patients with the TL rupture would not have met the rule of Spence criteria. So, although it is still there, we must ask if it is really necessary. I will not mention too much about the occipital condyle fractures and Atlanto-occipital dislocations because they are very, very rare, although some occipital condyle fractures can be seen more often in a very high resolution CT scans. Some clinicians cannot see that, they overlook it, and especially if it is an emergency case, the CT scans may not be evaluated by the expert radiologist at the time of night duty especially. For Atlanto-occipital dislocation, there has been a historical trinaris classification, and that author has identified type 1, type 2, and type 3. Type 1 is occiput has anteriorly dislocated, in type 2 posteriorly dislocated, and type 3 is just distracted. These are just anatomical features of the Atlanto-occipital dislocation. Probably that MR measurements of Harbour-Weave classification are somewhat more reliable. In those classifications, stage 1, stage 2, and stage 3 have been described. If the distraction is less than 2 millimeters, especially on provocative traction radiogram, if it is just 2 millimeters, or if it is more than 2 millimeters. If it's more than 2 millimeters, then here the medulla oblongata may get injured, and also the vertebral artery and some veins may get injured, and the ischemia of the region and significant traction of the region may cause very fatal injuries. In those injuries, the mortality rate may reach up to 30%. This is the Powers ratio, and other direct radiogram measurements have low sensitivity. Probably this condyle to C1 interval, if it's more than 1.5 millimeters, it is real instability sign. Let's come to atlas fractures. Atlas fractures are more common. We know all that Jefferson have classified them, but the recent classification from Weiler, a German author, describes that in five groups. This classification integrates Patterson and Dickman classifications. Weiler type 1 and 2 and type 5 are stable fractures. Type 5 is actually important because it is crossing the vertebral artery foramen, so then the injury to the artery may happen. That the injury to the artery must be excluded by the angio-CT. However, Weiler type 3A is a stable ligament intact. Conservative therapy in a hard collar is possible. You must follow up those patients, exclude dislocations, non-unions, and a possible Atlanto-occipital instability. Weiler type 3B is considered as an unstable fracture because of the transverse ligament is not intact. These cases must go to a Atlanto-occipital fusion surgery with some post-op hard collar application. Type 4 injuries, if it is a minimally displaced, hard cervical collar is enough, but some rare cases may have dislocations and may need a halo fixation for long periods. Let's come to the odontoid fractures. The Anderson and the Alonso classification has been used for many years. It's from 1974. Type 1 is very rare. It is just on the tip of the odontoid process. Type 2 is in the basis of the odontoid. Type 3 is crossing the body of C2. But in 2005, Grauer and co-workers have subclassified that Anderson and the Alonso classification with type 2A, B, and C. Type 2A is a non-displaced fracture. You can go conservatively. Type 2B is the fracture lies line is anterior superior to posterior inferior. You can then go to a anterior odontoid screw fixation. Type 2C is anterior inferior to posterior superior fracture line, or a comminuted fracture line. So this the treatment is rigid collar in two of them. Odontoid screw is possible with this one. Posterior fixation is possible is better with this fracture line. Type 3 may be managed with rigid collar. Actually, somebody may think or may still consider using halo, but halo is not a very easy thing to carry, and especially in the older persons, in geriatric patients, it's better not to use because the complications of halo is quite high. Let's come to the Hangman fractures. Effendi classification have been used since 1981. And there are 3 types, but Levin and Edwards have modified it in 1985. Type 1 has less than 3 millimeter displacement. You can manage it with a hard collar. Type 2 is more than 3 millimeter displacement, halo or anterior or posterior fixation. This is quite still discussable. Type 2A has more than 3 millimeter displacement and more than 11-degree angulation. Those cases must always be operated either with anterior or posterior fixation and isthmus repair. If you go from backward, then you can also repair the isthmus. Actually, as you know, Hangman fractures may also called as traumatic spondylolisthesis of C2. Type 3, the facets are dislocated, even locked at this level, and they are all more than 3 millimeter displacement and more than 11-degree angulation. Most surgeons prefer a posterior fixation in this case. Let's come to a unique upper cervical trauma, a combined atlas and axis fractures. Dickman has classified them in 4 groups, and the percentages of them is mostly 40% is C1 type 2 odontoid fractures, and these are the others. What are the options for management? If there is a C1 type 2 odontoid fracture, if it's a stable, rigid collar or halo is okay. If it's unstable, Atlanto-dental interval is more than 5 millimeters, halo or surgical fixation are options. If there is a C1 and different type of C2 body fracture, rigid collar is okay. It's mostly considered as stable. If it's a C1 and type 3 odontoid fracture, halo or surgical fixation. If there is stable Hangman fracture together with atlas fracture, then rigid collar or halo. If it's an unstable Hangman, then halo or surgical fixation are the options. So it's not very straightforward. So then stability must also be searched for by radiologic criteria mostly. And this is my algorithm. In case of trauma, mostly the main instability is an Atlanto-occipital instability. We must look at it if it's a reducible or irreducible. If it's a reducible Atlanto-occipital instability, mostly we can make just C1, C2 fusion. If it's irreducible one, which is not common in acute trauma, but in cases coming you lately, I mean, more than 2 weeks or months later, so then it may be irreducible one. So then you may need a decompression plus posterior fixation. If there is some sort of occipitocervical instability, then we must look also reducibility. If it's reducible, occiput C1, C2 fusion. If it's irreducible, anterior decompression plus posterior fixation, occipitocervical fixation. We need. Probably very shortly, I can talk about the craniocervical stabilization techniques. I will try to summarize them. Odontoid screw fixation, as you have seen in my slides, type 2B fractures of odontoid 2 fractures. These are good candidates, especially if it is a posterior dislocation. It's also a good candidate. So then the obliquity of the fracture line, as I mentioned before, is very important. Transverse ligament must not be ruptured. If it is ruptured, it's better not to make an odontoid screw fixation. Non-reduced fractures are not good candidates. Some surgeons do not like to do anterior dislocations. You can use 2 C-arm together or 1 C-arm, then you turn it to AP and lateral view very often during surgery. And you can place a gauze into the mouth of the patient to see the on AP view the odontoid process, because it may be conjoined with the teeth itself. So then by opening the mouth, you will see it better. Your incision line must be at C5, C6, and you must have a good angulation to reach the C2, 3 disc space, and place a key wire inside. And during that period, you must reduce the dislocation if there is some. Some surgeons prefer 2 screw technique, but I don't use it. And it is criticized if you use 2 screws, the screw diameter is about 3.5 millimeters. So then you will get less fusion surface, because the base of the odontoid is about 0.8 centimeters diameter. What are the alternatives to that? Anterior C1, C2 transarticular screwing is one alternative. C1, C2 plating is another alternative, but technically demanding. C1, C2 wire fixation, we have been doing that for many years. The most effective one is the Gallie fusion, but the original authors have described this technique after this wiring with a H graft taken from the posterior iliac crest. They need, however, a post-op halo brace. The authors have placed halo brace afterwards. This is a historic one, Halifax clamp fixation. We have left it. It is not in the market yet, since they were dislodging with the rotational movements of the head. Another one is the C1, C2 transarticular screw fixation. Actually, and there are 3 techniques for that. Anterior, I have shown you a few slides before. lateral is very technically demanding, but posterior one is has been used by many years. It is the so-called Magyar technique. But you need to make a very inclined screw entry to the C2, C3, from the C2, C3 facet entry. Some surgeons may prefer to make another incision at T1, T2 level, so then your screwdriver will take a angulation like this. In case with severe osteoporosis and upper thoracic kyphosis, it's not recommended. And another thing is the variations of the vertebral artery. Before surgery, you must have sagittal CT scans in the passing from the lateral part of the vertebral structures, so then you can see the entry point, the passing of the screw trajectory. If there is a so-called high riding vertebral artery, it is quite possible to injure the vertebral artery on one side. According to some anatomical studies, 20% of C2 body architecture do not allow to pass a safe trajectory. I mean, in 20% of the normal population, the vertebral artery will be injured. Besides, some surgeons prefer also adding some wire in addition to the Magyar screwing. So because of that important complication, many surgeons have left it, and they have came to use the Goel-Harms screwing. It was first introduced by Goel, then popularized by Harms in 2001. This is a C1 lateral mass screw and C2 pedicle screw. Because of the lower risk of injury to the vertebral artery and very good purchase of the screws, you can prefer this technique. C2 pedicle screws must be directed 25-degree medial and rostral. This is the entry point for C2 pedicle screw. Yes. What about occipitocervical fixation? Probably there have been a trend to make in most of the upper cervical problems to place an occipitocervical fixation. Even if there is just a C1, C2 instability, many surgeons have got too many occipitocervical fixations. It's not a good option because there are significant complications of occipitocervical fixation. These are some historical things, the Luque-Harschel-Ransford loops. We were using that together with sometimes with methyl methacrylate. This is some cases from my own series. Yes, I can just skip them. But recently, we have those rod plate and screw combinations, which make it very easy to apply occipitocervical fixation. These are some pictures from my own usage. And you can see in 1996, I was doing a hook clamp and a bent rod system, and then very long U-shaped rod systems, then in 2012, we started to use shorter fixations. Evolution of the technique was long fixation applications of all craniocervical pathologies without reduction. Now we are doing shorter fixations, separate indications. Reductions could mostly be achieved. What are the complications? CSF fistula may happen, cerebellar hematoma, and hardware-related complications. Screw loosening, pseudoarthrosis, and instrument breakage is very common. And most important thing is that the patient, after a occipitocervical fixation, have difficulty to rotate his or her head on all directions. So it is really a very disabling thing to make an occipitocervical fixation. Non-union is quite high. This is one of the cases I have operated years before. A rod breakage may happen because of non-union. So, in conclusion, C1 lateral mass, C2 pedicle screws are safer than C1, C2 are transarticular screws. Basilar invagination can be reduced with posterior surgery. It's not trauma, but I wanted to mention this. In case of occipitocervical fixation, shorter fixation must be tried, and autographs are better for fusions. Thank you for listening to me.
Salman. Okay, Salman.
Thank you, Mehmet. That was a wonderful talk. You know, just taking us through all CV junction various fractures and how you're going to deal with them, and what are the important things to look at when you're in the ER or when you're looking at these patients and their scans, and how do you diagnose and what criteria you should use. I think all that is wonderful. Obviously, you need to go back and read these up and just polish it. It's important that we know this. Do we have any questions? If you have any questions, please. So there's a question, what is the entry point for C1 lateral mass from Dr. Zaftam?
Yeah, actually, you must have a good dissection at that point because the venous plexus are very rich there, and you must see the lateral part of the atlas arch, and just below that you'll feel with a Panfield dissector, you'll feel the lateral mass. You can remove a small part of the arch and then directly come to the drill the lateral mass, and 24 to 28 millimeter length screw is enough.
There is a question, Mehmet. Do you remove the C2 ganglion?
In case I'm trying to reduce a basilar invagination, I do. I cut it because in order to enter the C1, C2 joint, this is a very robust ganglion. It doesn't allow you to place any spacer or any graft inside the joint. In basilar invagination, yes. But in trauma cases, no, it's not necessary. Just screw C1 lateral mass and C2 pedicle screw.
Okay, and do you have any more questions? I think the talk was so wonderful. So your classifications for each fracture that you described, can you just revise the names so that people can go and look them up?
Yeah. Somebody is asking about the YouTube channel. Probably you will deliver, or John will deliver it, the YouTube channel afterward.
Yeah, initial half of the presentation did not go through on YouTube, so John will look into that. Don't worry.
Salman, yes, I'll put the questions for your talk.
Yeah, I'll put the link on the chat box of the YouTube channel where it's going to go.
Sure. Okay, I've already replied to the questions that were put to me via this only, so that all is already done.
May I say something?
Sure.
I'm Nikolaos Sirmos from Thessaloniki, Greece. I want to only tell many greetings to my dearest friend Mehmet Zileli. I met him during the Mediterranean spine courses. He's a great friend and also a great teacher for me, and a great friend of the Greek neurosurgery. Dear Mehmet, many greetings. I'm very happy to see you again, and all the best. Also, my dearest greetings to Salman Sharif, also my friend from the spine courses all over the Mediterranean area. Also, the Professor Sharif, also many greetings and stay well and stay safe. It's a great honor to me to participate in these very good meetings that John Bennett organizes. I'm very happy and very pleased and very honored.
Thank you, Nicola.
Maybe in the future, from the coronavirus now that we have, maybe in the nearest future to see you again, and it will be a great honor for me to see you again, both Mehmet Zileli and Salman Sharif.
I wish the same. Yeah, we must turn back to normal very soon.
And all my best wishes also to Salman Sharif and Mehmet.
Thank you.
Thank you very much. We will switch on the mic for John. Can you switch on the mic for Nikolai Peeve?
Sure.
And his video as well. Sorry, Nikolai, we are not ignoring you. Just trying to switch you.
To say hello to Atul. Atul Goel's here.
Hi, Atul.
Are you there, Atul? He stopped it. He may have stepped out again. Okay, Atul, are you there?
Yes, very much.
Say hello to Salman and Mehmet. And
yes,
Nick.
yes, I heard the little bit of lecture of Mehmet, not so much. You know, I'm enjoying my holidays, and I had slept off. I put an alarm for 5 o'clock to hear your talks, but somehow I didn't get up in time. But I heard little bit of Mehmet's talk, and as usual, Mehmet is a different man. When he talks and when he interacts, he's different. But great talk.
Welcome.
Thank you, Mehmet. Everything okay?
Everything
Mehmet?
is fine. Everything is fine.
Salman?
Yes, Atul, as always, it's good to hear from you. And you need that rest. You deserve that.
Too much. But I had planned to get up exactly at 5, but couldn't. But you started late or what? Because it is.
No, we started at 5. 5 our time, which is 5:30 your time.
Okay.
Yes, Nick fell off there, Salman. So.
Atul can tell us something about basilar invagination in the meantime.
Yeah, I just heard Mehmet responding on C2 ganglion. So should I make a comment on C2 ganglion?
Sure.
Please do it.
Yeah, C2 ganglion is a quite a large ganglion. Sometimes in vertical height it may reach about 8 millimeters to 1 centimeter. So it is quite a large and thick one. So it occupies that space, and to expose the joint can sometimes become difficult in the presence of C2 ganglion. I used to cut C2 actually, when I started cutting C2 ganglion long time ago, and I reported it, of course, and I used to cut it all the time to get exposure of the C1 and C2 and the joint. But as I went ahead further in my business of craniovertebral junction, I have now almost stopped doing C2 ganglion resection. And I dissect it, I mobilize it up and down. I can expose the joint, I can do C1 exposure. But sometimes, as even Mehmet said, when there is basilar invagination, assimilation of atlas, and when there is severe basilar invagination, I will cut the C2 ganglion. Because for me, exposure of the region and completion of the project Like my project is 3 points. One is to expose the C1. Second is to expose the joint. And third is to do instrumentation. All these three have to be completed under vision. So when the vision is not there, I think cut the ganglion. There is no real harm in cutting the ganglion. And it exposes the window to C1, C2 joint. And wonderful, means the procedure of sectioning of C2 ganglion completely gives you a new world of exposure. So never hesitate, but avoid. That is my, that is my strategy.
Very good. That sounds very good. There's a question, Mehmet, do you operate early even if there are respiratory disorders with upper cervical spine injuries?
Yeah, it depends actually. It depends on the pathology. If there is significant instability to achieve a good alignment and to decompress the spinal cord, it may be necessary. For instance, I haven't seen any single case of leaving occipitocervical dislocation. I've seen a few, but they all were dead after 2-3 days. I would love to fixate them, but there was no such cases. Even there is no respiratory movements.
Okay, and what about even if they have a big contusion, like, we talked about that basics score, and if the basic score is 4 with big contusion going all the way up and down with hemorrhages in the cord, would you still do this, give them the chance?
Actually, your talk was very important that you were telling that Asia A score patients, 11% are getting some recovery or improvement to other levels. They become later Asia C or D. So then why don't you give them the chance of getting improved? In fact, I guess considering them as a Asia A at the beginning is a lack of good examination, because it's quite common even in our practice.
Right.
A patient comes that has no movement in the legs and arms, but the resident in the night or neurosurgeon in the night does not try to examine the perianal area. There are some sensation there. We then missed it. I mean, some of those cases of 11% have been in 11% because they are not examined well.
Yeah, I think there are two aspects, as you said, there could be spinal shock, one, or there could be that the examination was not done. So the rule is that you have to examine every hour for first 24 hours and document. And from then onwards, if the attending feels that, oh, we have done this surgery or we have done whatever treatment, then it's okay. Otherwise, every 2 hours for next 48 hours as well. And actual neurology, you will know in a patient in 72 hours, really. So I think in the meantime, you need to hypertense them. You need to make sure that they're decompressed. If they require decompression, if they're unstable, you stabilize them. If the tongues need to go in, you do that. In some patients, we use haldi, turmeric, as a routine. In some patients, I use ralazole, and these are some of the things that have been used and have shown benefit. But the main benefit that's been shown is you operate early, you hypertense them, and at the same time, you keep them in high dependency unit where they're aggressively nursed. They don't develop bed sores, etc. You get them to stand up on tilt table, etc. And if you do all that and you make sure that other complications like chest problems do not happen, then there may be a chance that these patients will improve and will have some kind of reasonable recovery afterwards.
You know, Salman, in the past, we had the knowledge that in case the patient has no respiration, and in case the blood pressure is very low, it's better to wait till they recovers. But with the current very nice intensive care unit tools, we have dopamine to increase the blood pressure. We have very nice respirators. We have very nice intensive care units. We can recover them, and then we can make the patients ready for surgery.
Okay, good. Nikolai,